Hello and welcome everyone. Today we're doing a journal review of this paper IMPROVE-2, which is personalized driving pressure guided PEEP in emergency abdominal surgeries. This was recently published in Intensive Care Medicine. So respiratory failure risk is a very common thing which is seen in high risk cases, especially where we are doing emergency surgery. So lung protective ventilation with low tidal volume PEEP and recruitment is a very standard practice. But how to find the optimal PEEP remains unclear. So driving pressure, that is delta P, that is P plat minus the PEEP, correlates with lung strain and patient outcomes, making it one of the key targets to optimize. So the knowledge gap is that there are observational studies and small trials have suggested that lowering the driving pressure may improve outcomes. But pragmatic multi-centered RCTs is limited. So the question that they are asking over here is, does targeting a specific driving pressure threshold will help us improving the clinical outcome over here? So is the highest PEEP to keep the delta P below a threshold superior to a fixed PEEP that we use in our usual practice of emergency surgical patients? So the study hypothesis was that individualized PEEP, adjusting the PEEP to keep a delta P less than 13, that is the driving pressure less than 13 centimeters of water. What they were expecting was lower post-op respiratory failure or death versus fixed PEEP of 5, which is standard over here. Mind you, many of the times we forget what is the population of our study. In this particular study, please remember the population is emergency patient who is going for abdominal surgery. It is not ARDS patient, it is not a pneumonia patient. So please do not translocate the findings of this particular study into your ARDS practice. This is a very common mistake where we just look at the title of the study and see that, oh, it's a PEEP titration, so PEEP level we are seeing and the PEEP has no impact. No, it's not. You have to understand what is the population over here. So the objective, what is the objective? The main objective is to composite post-op respiratory failure or all-cause death. Secondary is the individual components of this particular composite trial. Apart from that, you have ventilation, ICU duration, SOFA scores, organ failures, 90-day mortality, and various safety points. So the study design was that it's a multicentric RCT. Since it is a multicentric RCT, it has to be of pragmatic design with SSM masking. So 22 French hospitals were enrolled. And very important over here, remember this is the critical aspect of this particular paper. The target population was adults undergoing emergency abdominal surgery for more than 2 hours at the risk of respiratory failure. 1:1 randomization was done, stratified to site, shock and hypoxemia with intention to treat analysis. The study population, the key exclusions being more than 12 hours pre-op ventilation, home oxygen or ventilation, BMI of more than 40, unbrained pneumothorax or subcutaneous emphysema, or if the patient is very sick and imminently to die. So they randomized 707 patients, 679 were analyzed, which was intention to treat population, with 338 in the intervention, that is the personalized PEEP group, and 341 in the control, which is the fixed PEEP group. The baseline characteristics were well matched, ensuring a valid comparison. So the intervention protocol was something like this. The patient had to be on volume control, 6 to 8 ml per kg of the predicted body weight. I:2 ratio was 1:2, 30% end inspiratory pause, and FiO2 to keep a saturation of around 94. Recruitment maneuvers, a 20-30 second breath hold at 30 centimeters of H2O was done. The PEEP was titrated by decremental from 15 centimeter to the highest PEEP that can achieve a delta P of less than 30. So how did they did the maintenance? They repeated the recruitment maneuver hourly or after any disconnection, and they adjusted the PEEP by 1 centimeter steps until the delta P was more than 30. So the control group was fixed PEEP with no recruitment maneuvers, co-interventions being standard weaning protocol and rescue strategies. In the statistical analysis, they used chi-square for the primary outcome, robust Poisson mix model for adjusted analysis, Kaplan-Meier and Cox regression for time to event analysis, pre-specific subgroup analysis for the subgroup trials. As we have seen here, they were targeting a population of 680 with expecting a 10% reduction because of various causes, and they were expecting a statistical power of 90%. The study was designed with an alpha of 0.05 to detect a clinically meaningful difference in the primary composite outcome. So, what was the outcome? So, if you look at it, this is the intervention group, this is the control group. Okay, so this is intervention, this is the control. So in intervention group, you can see the median delta P was 7 and in control it was 9, and the median highest PEEP though was around 15, while in standard it was 5. Mechanical power was around 19 in intervention, and in control it was only 12. So the intervention did have a higher mechanical power, and less rescue therapies were used for hypoxemia events in the intervention group. If you look at the primary outcome, the unadjusted respiratory failure and in-hospital mortality was 25.7% versus 20.2, with the absolute difference of 5%, and the p-value was 0.08. The adjusted analysis, after controlling for the stratified factors, it yielded a p-value of 0.01. The intervention was associated with increased risk. So the personalized PEEP strategy did not reduce the primary composite outcome and showed harm over here. So what were the secondary outcomes? The reintubation NIV was 14% in the intervention group, and in control group it was only 7%. So that was again a huge difference. Non-significant findings in failure to wean, in hospital mortality, SOFA trajectory and other parameters, they were essentially non-significant. So problem again specifically coming from here only, that is the reintubation and NIV requirement. Regarding the tertiary outcomes, there was no significant difference in the safety profile. Ventilator events were essentially comparable. Protocol adherence was pretty good. So, clinical interpretation, the strategy did not reduce the primary outcome. They did find unexpected harm, and the likely mechanism could be the overdistension, especially since the population was having normal lungs. So, in this population, doing this type of intervention has never been shown to be of any value actually. Increased ventilatory intensity, as you can see here, the power was more. Probably they should have targeted power rather than going for the driving pressure. So in context with the literature, we have contrasting findings because we had small studies which had shown improvement, but clearly the physiological basis was not over here. In normal lung, giving higher ventilator power was definitely not going to give any good results. The study did have its strengths. It was having a pragmatic design, a good protocol, SSM masking and a rigorous analysis. However, it is severely limited because it is blinding, is not done. The variables post-op was not comparable across the group. The adherence was a little less. There was some missing data, and the generalizability is pretty bad. But then if you look at it in the general context, in the normal lungs and a higher mechanical power, the limitations are just too much. So if you look at it, the observational effect was smaller than the planned, and protocol deviations may have diluted the true treatment effect, making it harder to detect. Multiple secondary endpoint analysis without multiplicity adjustment, increasing the risk of false positive findings. So the conclusion is that this particular strategy did not reduce the post-operative failure or mortality. The intervention was associated with the need for reintubation and curative non-invasive ventilation. So this pragmatic trial essentially failed. So the clinical application is nothing much changes. We do the same things. There is no role of individualized PEEP in this particular population. And rather than going for delta P, we would recommend